The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar on Child Life Services and Benefits for Families and Patients, hosted by the Children's Cardiomyopathy Foundation and Transplant Families. We are glad that you're joining us this afternoon and hope that the presentation is helpful and informative. My name is Gina Petty, and I'm the Director of Family Support and Outreach Services at the Children's Cardiomyopathy Foundation. If this is your first time joining us for a webinar, welcome. We're glad that you're here. If you've joined us in the past, welcome back for this session. Before I turn the presentation over to our guest presenter, we have a few housekeeping notes before we begin. If at any point during the presentation you need technical assistance, please type your question or concern in the chat window. If you have any audio issues, you are able to switch between using your computer speakers and your phone if needed. In order to provide the highest quality session today and avoid background noise, all attendees are in listen-only mode. Your questions are encouraged and welcome during the presentation. Questions can be submitted via the question box located in your control panel. We will be taking questions during the last 10 or 15 minutes of the presentation, so please submit your questions as you think of them, and we'll address them at the conclusion of the talk. We will also be recording this webinar, so you will be able to access the information again at a later date. I'd like to take a moment to welcome and introduce Melissa McQueen, the founder and president of Transplant Families. This week, April 23rd to 27th, is National Pediatric Transplant Week. In support of the week, CCF worked together with Transplant Families to offer 2 educational webinars as well as other awareness initiatives. We are thrilled to be collaborating with Transplant Families on this project. Welcome, Melissa.
Thank you so much, Gina, for the introduction. Transplant Families was founded in hope to support, educate, and inspire pediatric transplant families for all solid organ and bone marrow transplants. We are so happy to celebrate National Pediatric Transplant Week in collaboration with Children's Cardiomyopathy Foundation. Proud to work with CCF and all the other support organizations, hospitals, medical professionals, and many others that make pediatric transplant a much easier journey. Every day after transplant is truly a gift for us, and we thank you for that. It is now my privilege to introduce Brittany, who is a certified child life specialist that received her master's degree from the University of Missouri, with special emphasis on trauma and crisis in adolescents. For the last 6 years, Brittany has worked as a child life specialist, providing therapeutic support and child life interventions to families across Chicago. For the last 4 years, Brittany has served kidney, liver, and bowel transplant patients and their families at Lurie Children's Hospital of Chicago.
Hi, everyone. This is Brittany. Thank you so much for having me, and I'm looking forward to talking with you all in regards to child life services and how we work with patients and their families. Some of the objectives for today's presentation are to explain the role of child life specialists. Hopefully, you'll gain some comprehension of how hospitalization stressors differ between different developmental stages, discussing the various stages of the transplant process and how each stage causes unique challenges for patients and their families. I want to give some techniques that child life specialists use to concretely support patients. And then hopefully I'll be able to answer some questions or concerns that you all may have, and we'll go from there. So what is a child life specialist? Child life specialists are developmental experts, part of the team who assess and educate coping. We work with adjustment issues, comprehension of patients and their families through diagnostic education. We do developmentally appropriate preparation. We provide expressive activities. We help patients really master their challenging experiences in the hospital. Because we understand a child's coping is rooted in family systems, child life specialists provide support and anticipatory guidance to parents, caregivers, peers, other family members to help support them so they may better support the patient. So here are a few things that child life specialists do, and this, I should clarify, is not just specific to transplant patients, but this is something that we do with all of our kids and teens that we work with and their families. So providing diagnostic specific teaching, helping patients understand at their developmental level what is going on. providing preparation for medical procedures, surgery, treatment. We use specific books, language, a variety of teaching materials to help increase understanding, and the increasing of understanding for a patient and their family then in turn helps reduce stressors. We provide sibling support. Often, I think people forget that the siblings are a huge piece of this hospital process. So we really want to help siblings understand the diagnosis and help them work through their feelings, answer their questions, and help ensure that siblings are continually connected to the family while perhaps a caregiver is always in the hospital with the patient. We provide procedural support. We do that by modeling positive coping strategies using developmentally appropriate distractions. Medical play is important. Children learn through play, and so it's really vital to us that we utilize play in a way to help enhance understanding and clarify misconceptions. We, through medical play, use specially adapted dolls as well as real or pretend medical equipment. I personally love using real medical equipment when I do medical play with patients. It helps desensitize them to some of these tools that are used and makes, again, just reduces the fear for them. Sometimes a child may not be able to verbalize their misconceptions, but we see them as they're doing play. By that I mean, I've seen a child take a flush and then stab at the doll that we're playing with. And because to them, what they're saying to me is that they find that pretty invasive. So we go ahead and talk through that then, or play through that, and help, again, clarify that misconception of what they see is happening versus what the team is actually trying to do. Providing emotional support is extremely important. We want to help kids process their experience, work through their feelings and anxieties. We work on letting kids know that the emotional side of being in the hospital is so important to their recovery. It helps with their physical recovery. We've got a lot of studies that prove that, and so we really want to make sure that they are coping as best as possible so that they can physically get better. We work on helping to manage pain by offering various non-pharmacological techniques, comfort positioning, guided imagery, deep breathing, and other methods. We work with children with special needs by individualizing care and adapting the environment around them, and provision of resources. This is important. Learning doesn't stop when you leave the hospital, nor does the need for support. So we really want to work with patients and families to make sure that they have all the resources they need so that when they're discharged, hopefully, or in between hospitalizations, they have continued resources for gaining knowledge, having support. And then we work with behavioral modification for kids displaying unsafe behaviors or being non-compliant, and work with them on figuring out why these maybe regression or these behaviors are occurring, and then what we can do to help reframe that behavior to make it more positive and more safe. So I was asked to go through and talk about the developmental characteristics of hospitalized patients at different developmental stages, and then talk a little bit about what Child Life does at each stage. I'm hoping that this will be helpful for you all as perhaps some caregivers are listening in, or other medical professionals that can understand then what are some of the big characteristics that are causing challenges or fears for different developmental stages, and then different interventions that we can do to help ease those. So for infants, pain is a big thing. I think oftentimes people forget when, a lot of times people will say, oh, they're so little, they won't remember. Well, actually, we found that that's not true. There's some muscle memory there. There can be some ongoing fear. So we want to make sure that we are doing appropriate pain management for infants as well. There's a lot of overstimulation that can occur in the hospital. I'm sure anyone that's been in the hospital you can remember all the beeping and bells and noises and people coming in and out. And it's a lot of overstimulation, oftentimes for us adults, let alone for an infant whose brain is still developing. The disrupted routines can be really difficult for an infant. I'm sure parents also recognize this, caregivers who are trying to get their baby on a routine. It can get thrown out the window completely while in the hospital, and so we want to work on that. And then interruptions to development, oftentimes different medical procedures, let's say, babies with a new chest tube or other sorts of recent medical interventions may not be able to do tummy time as they would like, or work on their sitting up due to whatever medical equipment they may be having on their bodies. And so that interrupts their ability to continue meeting developmental milestones. For toddlers, stranger anxiety. And again, when you think about how many children meet at the hospital, it is said that there's approximately 30 people in the first 24 hours of an inpatient stay. So when we're talking about toddlers who have stranger anxiety, that is an extreme amount of strangers being entered into their life. So keeping that in mind, fear of bodily injury and pain, immobility and restriction, this is huge. When you think about toddlers, they're really starting to feel autonomous over their body. They're starting to say, I want to do, and right, you're giving them that freedom to go and explore. And then they come to the hospital and they are being restricted. Maybe they're restricted just to their room because of isolation, or perhaps, one arm is wrapped in an immobilizer because we're protecting an IV or a PICC line. And now they've lost some of that freedom of movement with their extremities, and that can be extremely frustrating. So we want to keep that in mind. And then forced regression. So toddlers that were potty trained, but now physically maybe can't get out of bed to use the bathroom, so are forced to, rather go in a bedpan or wear a diaper, and what that looks like. So some of the interventions that we do for that would be, for infants, provide individualized level of stimulation, recognizing the cues for infants on what they're tolerating and not, and then come up with a specific care plan of ways to help rather provide stimulation or continue to reduce stimulation, depending on what they need. Advocating for comfort holds. This is huge. And what's great is that advocacy for comfort holds and utilizing one voice is something that anyone can do. The one voice technique is just dedicating one person in the room to be the person that speaks, so that we are, again, not overstimulating the infant. And one voice is actually fantastic for all developmental stages. I put it here under infants, but it goes across the board. We want to work on helping infants return to baseline quickly after procedures. We work on fostering caregiver-baby interactions, so really ensuring that caregivers, if a lot of times they feel really nervous about holding their infant due to lines and tubings and whatever the case may be. So really working with caregivers on ways that they can still interact with their babies, safe ways to be holding their infant, and then focus on the development of what the baby can do. So often it's really noted on all the, they're not doing this, they're not doing this, they're not meeting this milestone. So we really want to focus on some of the positives of what the baby has been able to do and things that we can continue to do to help them meet the milestones that are possible while they're being hospitalized. For toddlers, again, fostering the interactions between the two, providing education and modeling for caregivers. We want to facilitate preparation and medical play. This goes back to really the importance of play for children. It's how they learn. Toddlers are so creative and imaginative, and I love that about them. So giving them an outlet during medical play can really help us understand what the misconceptions or fears are, and then we can work on redirecting them. Providing support during procedures, promoting therapeutic play, and giving choice and control within limits. So I kind of pointed out earlier about the loss of autonomy for toddlers. So we may not be able to give them full autonomy. They may not have use of that left arm because the IV is in there and it has to be immobilized because that kiddo is trying to pull it out otherwise. But then giving some options of things that they can do. So, do you want us to take your blood pressure in your left arm or your right arm? Do you want, caregiver to give the medicine, or do you want your nurse to give your medicine? Different control and choices are so important to building up some trust and letting that child feel like they have some control and freedom. We really also talk about how parents are coping. We want parents to understand and caregivers to know that an anxious caregiver will cause a child to feel anxious. So keeping that in mind, understanding that the hospital setting is not just stressful and cause anxiety for patients, but very much so for the caregivers, their extended family, their support groups. So really working with them on supporting them and figuring out ways to allow caregivers breaks, helping them manage their anxiety. We also discussed the use of positive language. So oftentimes in a procedure, you'll hear people say, oh, I'm sorry, I'm sorry, I'm sorry. What we as child life specialists like to do is change that dialogue. So instead of saying I'm sorry, saying something along the lines of, I know that you were scared, but I'm here for you. I know that might have hurt, and I'm sorry that it felt that it hurt, but this was important for us to do to help you get healthy. Just saying I'm sorry to a toddler or school-aged child tells them that something was wrong, right? So we teach kids to say I'm sorry when they've done something wrong. So if you're saying I'm sorry, then we're telling them, well, we've done something wrong. Whereas that's not the case. You're doing something to help promote this child's well-being. And I understand, you always want to say you're sorry when a kiddo is upset and crying, but really work on making that language more positive and direct so that children understand that it's not that we've done something wrong, but again, that we're trying to help them. So some characteristics of hospitalized preschool and school-aged children. So for preschool, we've got magical thinking, a lot of misconceptions, literal and comprehension. This is a big one we see in the hospital. So when you think about it, we talk about flushes in the hospital. So for most preschool kids, they've been potty trained, they think of a flush as a toilet. Or we'll say, oh, we're going to give you an IV. Here in Chicago, I've had a kid say to me, oh, IV, like the plant at Wrigley Field. No, actually, that's not what we meant. So keeping in mind that a lot of the acronyms that we use at the hospital or a lot of our language maybe is a little bit more figurative, and they're so literal in their comprehension. So keeping in mind what language we choose. Knowing regression can occur. Oftentimes preschool children see hospital as punishment. And then again, we're going back to a lack of autonomy. For the school-age children, feeling the loss of control, again, this is going to be big throughout all age groups. The fear of death or never being well again. This is so hard, but it's so true of school-age kids where they really understand more of that permanence, and then they have this fear that their body is always going to be this way, they're never going to be well again, they'll never see their friends again. With school-age children, they're starting to gain a lot more interest in learning and acquiring knowledge, so really giving them the opportunities for that. And desire for acceptance among peers, anticipation or fear of pain, and then we're starting to have those modesty concerns. So as child life specialists, some things we do for preschool students is to reinforce the reason for hospitalization, reaffirming that there is nothing that they did to cause their disease, their hospitalization, their injury, whatever the case may be, encouraging independence, choice, and control, providing verbal and nonverbal outlets for self-expression, offer acceptable outlets for physical release. I think this is really important. I think a lot of times we try to pull back on giving kids some of that opportunity. But we can provide outlets in a safe way. So whether it be shooting baskets, getting that throwing action, or tearing paper up. We've had kids tear up a whole bunch of confetti that we can later use for transplant celebration, but that can be so therapeutic to rip a bunch of paper into shreds. Something so they have that physical release, because talk therapy is super fantastic, as is therapeutic expression in art and music, but sometimes they just need that physical release. We continue to promote medical play. Incorporating home routines can be very big in helping reduce the regression. Oftentimes in the hospital, it is very difficult to have a set schedule, but what are some ways that we can come up with incorporating those home routines? So is there a specific song at bedtime, or is there something that you normally do first thing when you wake up, and incorporating those things? Offering predictability and structure. Educate in developmentally appropriate language with concrete explanations. So again, that goes back to how literal preschoolers are. Another example I just thought of was a heart transplant patient who's talking about how they were worried that they would love different people once their heart was taken out and they received their transplant. Because, we often say oh, I love you with all my heart, or you have my heart, or heart is where in society people connect love with. And so this child took that very literally and thought, well, I love you with all my heart, and my heart's not in my body anymore. then am I going to not love the same people that I loved before? So that was really interesting to hear that perspective, and just really reminded me of how literal preschoolers think. For school-age children, we work on very detailed, specific preparation. Like I said before, often these kiddos are really looking into gaining more in-depth information, so we really want to provide that preparation. Encouraging questions, encouraging them to be part of the conversation. Work with them on identifying coping strategies. Kids at this age are becoming much more self-aware and understanding of what's going on, and so letting them, again, be part of that conversation. What do they think would be helpful? Providing ongoing outlets for expression, promoting communications with peers, giving them that opportunity to interact with the team, and then provide opportunities for success. So that kind of goes back to also having choices and just having some freedom and giving them opportunities to not just feel like things are happening to them, but they're part of the process. And then our teens, which I personally have to say are my favorites. They really struggle with the lack of privacy. That goes back to, the body modesty that starts with our school-age kids, very much continues into teens. The body image issues, feeling a decreased connection to their peer groups. Again, this decreased independence is something we'll see, as I said before, through all the developmental stages, and a fear of judgment. So some of the big things that we're going to do to help teens cope through their hospitalizations are providing opportunities for autonomy. So again, giving them as many choices and opportunities of freedom as possible. Ensuring that they're included in medical discussions. I think we all can agree that most teenagers very much feel like adults and want to be part of what is going on. We always like to remind them that we don't want things to feel like it's happening to them, but that they are part of this discussion. It's happening with their insight, with their knowledge, with their choices being considered. We work really hard on facilitating peer interactions. Peer groups are so vital for teens in their coping. So we work on figuring out how we can make the peer interaction continue to be a thing throughout lengthy hospitalizations or maybe short-term but very frequent hospitalizations. We work on building a lot of deep rapport with teens. Sometimes teens can be hardest to get to communicate with, but the longer that we build a relationship, we find the more open and trusting they are, and then they will discuss some of those deep-rooted feelings of anxiety or concerns that they have. The body image issues, oftentimes kids worry about, or teens, I should say, worry about what the surgery, what the medical intervention is going to do to their body. So what is that scar going to look like after transplant? Is the PICC line going to leave a scar? Is my body going to function differently now that X, Y, or Z has occurred? So really talking through with them about what that's going to look like and helping ease some of those fears. And then getting through with them on the fear of judgment. What do they want people to know? What do they not want people to know? What do they want their dialogue to look like? And how we can help them feel in control. Okay, so now I'm going to talk about some things that are a little bit more transplant specific. Pretty much this slide, and then everything else goes back to being pretty much what we do with all patients. But a transplant evaluation is a really important way for child life specialists to better understand the patient, their history, their family stressors, their family makeup, their support group makeup, and then what strategies may best support them through this whole process. Transplant evals may be done by other members of the psychosocial team as well. So sometimes it's not a child life specialist, sometimes it may be a developmental specialist, a social worker. It just varies on the hospital and the case sometimes too. I typically do these outpatient in clinic, but location can change depending on type of the transplant and the patient situation. So a patient may come in for one reason, and then through the length of their stay, we find out that maybe the previous course of medical interventions have now caused some damage to the kidneys, and they may now need to be a kidney transplant, look into kidney transplants. So that can all change. So a few of the things we go over. Does the patient have a developmentally appropriate comprehension of transplant. This is really important. We need to know from the get-go, what does the child understand? This goes back to clarifying misconceptions, reducing anxieties, making sure that they know at their level what is going on. Again, we want to make sure children feel like things aren't happening to them. We want them to feel secure in what's going on around them and that they're being part of that. Does the patient have siblings? Again, siblings, the whole support group, family system is so vital. We're not just treating a patient, we are treating all of those in their family. And by family, I mean their friends in school and other peers. So this is a big round group of people that we need to really work with and understand how they interact with the patient, because that will then help us understand how the patient's going to cope through all these different phases. What's the patient's medical history? So, understanding that helps us know, do we have to go from IV 101, like this is what an IV is, here's what it looks like, or is the kid already mastered that, they understand an IV, they cope really well with that, but we've got these other questions or concerns coming up. How does the patient take medications? This is very important. When it comes to transplants, a lot of children will need to take a significant amount of medication pre-transplant as well as a significant amount of medications post-transplant. So we like to find out if the patient's currently compliant, if so, what techniques are working really well right now, and recognizing that compliance can change very dramatically throughout developmental ages. So keeping track of that. I apologize, that says how soothes the patient, but to say what soothes the patient, what distracts the patient. So this is us starting to come up with a coping plan. How does the patient communicate their needs and feelings? This is important because not everyone communicates the same way. Some children are very comfortable with spoken language. Some children don't have spoken language as an option or choose to communicate in other ways. So what is it that's going to help them best communicate so they can always feel that they are being understood and being part of the process? And then what are the patient's educational, developmental, sensory needs? Again, we want to make sure that kids have the opportunity to self-regulate or utilize sensory items that will help them with their coping. So this says pre-transplant, but this again could go for any child pretty much that's coming in through the hospital for outpatient surgery, an unplanned or planned inpatient stay. So we like to discuss current emotions. How is the child feeling at this moment? What are any anxieties, concerns, worries? We also then identify and correct misconceptions. So this goes back to like making sure that they have a really good understanding of what's going on and being well prepared. Our preparation includes very honest conversation in age-appropriate terms. So no matter your child's age, the most important thing you can do is to be honest. This can be really challenging because a lot of times caregivers worry about their child's ability to handle the news. How are they going to cope with this? But what we have found is when children are given the information in a supportive and developmentally appropriate way, they're better able to understand the information, they're better able to cope. And so being open and honest, if you're hiding something, if you're being not truthful, kids will understand that, and we never want to break trust. Us as medical professionals, but we also want to ensure that caregivers and the supportive family and friends around the patient are also not breaking that trust with the child. So we provide developmentally appropriate medical prep for different interventions. Before transplant, there's a lot of x-rays and labs and different imaging. So making sure that they have really wonderful in-depth understanding of what that looks like. We develop a coping plan and discuss pain management techniques, and I'll get into that a little bit more in a minute. Medical play, we utilize teaching dolls, prep books, videos, whatever. This goes back to that question I asked earlier for the transplant eval is, what is their educational needs? So everyone can learn, everyone learns in a little bit different ways. So as a child, that a book is the best way for them to read and keep reading and understand. Are they more of a visual learner? Is doing medical play can be more beneficial, or is a video? So really figuring out what that child will, how that child will best learn, and then meeting those educational needs with our prep. And then we like to prepare kids on the different sensations that they're going to experience. So, what is this going to taste like, feel like, sound like? All of those are so vital. And then before OR, we also prep about what it's going to be like when they wake up in the ICU. This can be something that can be really challenging because it's different, I suppose, at different hospitals, but I will say here, our kids can wake up being intubated and be awake and alert, and communicating verbally around an ET tube is quite challenging. So we want to talk ahead of time about how they think they would best like to communicate once they wake up with that tube in place. So we have attention-getting tools like bells where they can ring and then they may want to point to different things. We have recordable buttons, and this is something that is a pretty easy thing to do, that you can have a couple buttons on a machine that they've pre-recorded to say, you know, I'm in pain, I want TV, I need, you know, I need mom, whatever the case may be. We have dry erase boards, pencil. A lot of kids these days obviously like to do texting and then show you what it was that they wrote up. But talking about those ahead of time, that will help them feel more in control and feel more secure in what's going on, that they can continue to feel part of that communication, part of that discussion about what's happening around them. And then we talk about uncomfortable tubes and uncomfortable places. So again, waking up with an ET tube, they'll probably have an NG or an Anderson, they'll have a Foley in place, potentially art lines, potentially multiple IVs. So just letting them know ahead of time that they're going to wake up with all of this. Now, everyone copes a little bit different. So for some kids, knowing all of these details ahead of time may be overwhelming, but we want to set them up for the most success as possible. So recognize that some of these things I am saying may have to be adapted because every child is going to be different in their how much information is too much information, as well as what's going to help them cope the best. And then come up with a plan. So encouraging children to participate in their care and offering choices. That is going to be, again, that's very consistent for everything that we do. Choices, choices, choices are so important for kids in their coping. Putting the coping plan that we've developed up on their door in the ICU, putting it in their medical record, making sure that all members of the team, and when I say the team, I'm not just referring to child life and social workers and nurses, but you know, the wonderful people from food services and environmental and whatever the case may be, all understand what's going to help them best interact with that patient and family so that we're setting up this family and the patient for the most success as possible. Coping with the unknowns is a really hard part for patients and families that are waiting for transplant. So often I've spoken with families about that constant uncertainty and this waiting, knowing that at any minute that call could come. So what is it going to look like when, you know, do we plan a family trip? Can, you know, we expect her to be in the high school play? Is, you know, is he going to be able to go to his dance recital on Saturday? I don't know. The call could come at any minute. So helping families feel prepared as much as possible, supporting them through this uncertainty, because, you know, the call could come in a minute and they have to drop everything and go to the hospital. So missing out on those normal activities can be a stressor that the child may come to the hospital with. You know, oftentimes we'll hear kids wanting to be really excited about their transplant, but, you know, Drake's birthday party was supposed to be on Friday night, and now she's going to miss it. And some of those just peer relation interactions that then get changed and missed out on, that can be really hard. The uncertainty of how long recovery will be. This can look different for different kids, obviously, especially with the different types of transplants. So that is really frustrating. Oftentimes, will a transplant work? This is a big question we get. And, you know, we never want to say to a kid, oh, yeah, it's going to work. It's going to be great. You're going to be fine from here on out. Because unfortunately, as we know, that may not be the case. So what we try to say is, you know, the team did everything they can to set you up for success. You know, you do the best that you can do. We did the best we can do. But rejection is a possibility. We want to make sure that kids understand that we're not going to lie to them, that we're not going to set them up for something, making promises that things are going to be perfect from here on out, but, you know, letting them know the importance of them continuing to be compliant, them continuing to do their job, that the medical team is going to continue doing everything they can. And as a team, we're going to work as hard as we can to make this transplant successful. How will I be different physically, mentally, emotionally? This is something that our heart transplant child life specialist was talking to me about, that she's had some of her heart kiddos talk about that they have a different appetite and different taste buds after transplant. Goes back to I was telling you about the heart transplant patient before who asked, am I going to love the same people? How's my personality going to change? So kind of talking with kids through this. And then the expectations versus reality. What patients think life will be like post-transplant and what their reality might actually be like. So the development of a coping plan, this is something that we do with all patients. It's really important. This is something that anyone can do with a patient. It can be done, just for your dentist visits or just for, annual vaccinations or whatever the case may be. It's just setting up a patient and their family for success to make the environment the least stressful, reduce the anxiety as much as possible. It not only helps the patient and family, but it also actually very much helps the medical team as well. When a coping plan is in place, kids and families are able to hopefully have the least anxiety, be coping the best as possible, which then in turn makes the work that the medical staff is doing that much easier. So again, asking a patient and family what is soothing and comforting to a patient. Is there a favorite stuffed animal? Is there a favorite song? What is stressful for the patient? Some people, say, oh, this part's not going to hurt at all, as they put on the blood pressure cuff, but that actually might be the thing that sets a kid off more. They might be able to do their daily injections way easier than they can do that blood pressure cuff. So keeping that in mind and letting us know what is the stressful piece for the patient. How does the patient communicate? Are there developmental delays? Are there sensory needs? What does that family and peer support system consist of? Again, the family system is so vital. And so what does that look like? What are the dynamics? How does that support system collaborate together? And then again, how does the patient learn? Are we going to be working on more visual, more auditory? What is that going to be? Coping plan, again, is not just for child life use. It informs everyone how to best interact with the patient to reduce anxiety and stress. So this is just a win-win for everyone. So some post-transplant interventions. And this is, again, it says post-transplant, but I want everyone to know these are things that child life specialists work with for all patients. And it's an opportunity that a lot of these things most people can be really cognizant of. And think about this as your child or the patient you're taking care of is going through just their, again, outpatient, inpatient, whatever it may be, hospitalization. So medication compliance. As child life specialists, we have pill swallowing kits, so ways to support taking meds on a regular schedule as well. We also discuss the importance of ongoing compliance. Compliance can change drastically as the patient moves into different developmental stages. And so that medication compliance discussion will look very different at age 6 than it does at age 12, than it does at age 20. So we want to make sure that it's an ongoing discussion. The other thing that we notice is that compliance changes as side effects of medication occur. So we'll see oftentimes a patient may be really compliant with the medication until they're recognizing that the steroids are making their face puffy and they no longer want to look like that. Again, goes back to that fear of judgment, being accepted by peers, feeling confident in their own skin. And so as they maybe are becoming more swollen and puffy through various medications, they may stop taking them. And so we talk to them a lot about that importance of continuing to be compliant. Many adolescents become less compliant because they want to fit in, they want to be normal. I'm using air quotes there for, you can't see me, but certain drugs, certain medications make hair grow in unwanted places. So again, all of that can cause non-compliance. So we talk a lot about that. Procedural support, again, coming up with the coping plan, having alternative focus techniques. Ambulation is huge post any surgery, but especially post-transplant. So we work on incentive charts, providing encouragement, and really identifying when the patient is meeting different milestones of, now you've stood up for the first time, you've sat in the chair, you walked around your room, you made it to the nurse's station, whatever the different milestone may be, making it enjoyable too, walking around. So we've done things like doing fun activities outside the room. Like if you can make it to, the window by room, 44, then there's a beanbag game to play, or we decorate a walker. We had one of our transplant patients, we made his walker into a race car. So different things to make it really fun, going on a treasure hunt, encouraging ambulation, but in a way that is playful and fun for patients. And then sibling education, again, where are siblings developmentally? What is their level of comprehension, questions, fears, concerns? How are they going to remain connected to the patient? This is very huge. We currently are under restrictions, visitor restrictions, because of flu season. So we have some siblings that are not able to come visit their inpatient sibling. So what does that look like? We do a lot of FaceTiming. I love doing the journals back and forth where the patient writes something one day or draws a picture, and then the caregiver brings it back, and then the sibling sends it back, helps them feel really connected. Sometimes we'll have siblings do room decorations for a patient so that when the family is like taking pictures or FaceTiming or Skyping, or even just talking on the phone, the patient can say, oh, I got the giant teddy bear you drew for me. I really appreciate that. Just helping them feel more connected. The same thing is going to go for peer support and peer education. What does the patient want their peers to know? So we really want a patient to feel in control, help them feel like they're directing their narrative. So who do they want to know what's going on with them? What do they want those people to know? And letting them engage in what that conversation is going to look like with their peers, and helping them feel connected. Again, especially when we're on restrictions, how can they still be connected to their peers? Another big thing that we notice with peers is there's a reduction in peer interaction, and then there could be big changes in how the patient can interact at school. So maybe new restrictions on the sports they can play or the things that they can be involved in. So what does that look like? Maybe they can't play the sport anymore, but can they be the team manager? Can they be the official photographer or writer for the school paper on their sport, whatever the case may be? We see a change in what crowds the patient can be in, a need for their PICC line or the central line or mask, which changes their outward appearance. So keeping all of those things in mind and giving them support and an outlet to talk about these things. Emotional support, again, a lot of times we'll see some depressive feelings post a surgery, but especially post-transplant. We see this a lot of times with kids that felt pretty well-being before transplant, and now are feeling more sick and less autonomous. That can be really, really frustrating. I've had patients say, "Why did I go through this? I felt better beforehand." And sometimes they don't understand that although they might have felt better beforehand, eventually their bodies would have gotten extremely sick. They maybe wouldn't have been a candidate for a transplant. So we want to help them feel like they can understand a little bit why this transplant went through. Sometimes patients will see other patients on their unit recovering and compare their progress to other patients. And that might be really frustrating. We like to remind patients that everyone is unique in their recovery and in their challenges that they may be faced with, and so how that can look different. And then also we see depressive feelings as patients realize where organs came from. Now, obviously, some organs come from living donors, but oftentimes they come from deceased donors. And so we have to talk with kids about what that looks like, and that can be really challenging, or providing coaching to parents about having those ongoing conversations when the time is right. And again, that can be really hard. Child life specialists will sometimes do support groups, whether formally or informally, but an opportunity to connect patients who have gone through similar things to help them feel not so alone, normalizing their feelings, getting them connected to some peers. And then we do normalizing opportunities and pain management. So these will be pretty quick. I just have a few more slides, and then I want to have some time for asking questions. So for normalization, room decorations, I've got a great team of volunteers that can make some really wonderful decorations. We want to make a room feel unique and specific to a patient, things that they'll enjoy looking at while they're here recovering. Celebrating milestones is a big deal for us. We do kind of like a human tunnel, as if you would, like, you know, when you're watching like the NBA or the NFL and there's people on both sides and the people run through the middle. We do that for our kids as they go down to transplant. We ring cowbells and blow bubbles, and I say we, I mean like everyone on the team. Again, doctors and nurses and social workers and music therapists and people from environmental and pharmacists and whoever is around that wants to help celebrate this amazing thing that's about to happen. And then post-transplant, we give them a big old load of presents as it is their new birthday, and really want to make them feel special. We also want to make sure that when they're here at the hospital, their holidays, birthdays, anything else that's really special to them is being celebrated. Normalization of the communication techniques, again with the picture boards, flip boards, buttons to talk, whatever it may be needed for them to communicate to help the environment feel less stressful. Setting up a schedule as possible, depending on the unit and the transplant or the reason for hospitalization in general. Schedules can be quite tricky because different things can occur at variant times, which then can cause actually more stress for the kid if we say, you know, PT is happening at 2 and then for whatever reason PT can't happen at 2. So the other thing that we can do is a checklist, which is kind of my favorite thing. Different things that a kid has to get accomplished each day to kind of regain some sense of normalcy. So, you know, you've got to brush your teeth twice a day, and you've got to work with the school teachers once. You have to, you know, make sure you have time for play. You know, there's got to be at least 2 hours of building Legos, painting, making slime, whatever it is that makes you happy and makes you feel like yourself. We work on clustering care so that there's less interruptions. So we'll advocate for, you know, if a team's going in, how many people can go in to get what they need to be done at one time without overwhelming the child, but then also with reducing the amount of, again, interruptions. Doing medical play with child life specialists, again, this helps clear up any misconceptions, reduce anxiety, and increase comprehension and coping. Having volunteers go and visit and just doing some normalizing play, fun opportunities to just hang out with someone that's not there for anything else but building Legos, and then other supportive departments. So we work really closely with playroom staff, music therapy, art therapy, school teachers. We're lucky enough to have musicians on call and magicians and a whole assortment of really fun outlets for kids that are rather therapeutic or just distractional and diversional, which is super important as well. And then finally, some pain management techniques that child life specialists use, again, not specific to transplant patients, but for kids in general. We really work on understanding the distress signs of children at different developmental stages, and then making unique plans to meet the needs of those kids. So Buzzy Bee is a great tool. It's something that people can get on Amazon, but it does nerve confusion. It's just a little buzzer that provides vibration, and that is a wonderful tool to use for shots and IVs. We really advocate for comfort holds. I know there's quite a few hospitals that have some really wonderful resources on positions for comfort. So I'd recommend, you know, finding those out. That's something, again, you can ask to utilize in any setting, whether it be at your pediatrician's office or inpatient, but it's a great way to help support a child and make them feel more secure and help enhance their coping. We go through deep breathing techniques, alternative focus opportunities. So really working on what kind of alternative focus may help. Some children are information-seeking copers, which means they want to watch every single thing that's going on, and that's fine. I think a lot of times people think, oh no, tell them to look away, they shouldn't see this. But for some kids, watching is actually what helps them cope. So we want to keep all of that in mind. And then we utilize the 5 S's of infant pain management: swaddling, sidling, swaying, shushing, and sucking. And then using sucrose water with that sucking can be really helpful in managing infants' pain. So those are some pain management techniques that we as child life specialists use. But again, these are all things that I really want to encourage other medical professionals, caregivers to know, to feel strength in utilizing this information, knowing that this is something that you can advocate for your child or your patient across the board. We always want to, as child life specialists, to empower everyone to do these tools, or to utilize these tools to best help kids cope and reduce their anxiety, because it's something that we can all work together on to make children feel supported, secure, like they understand what's going on, like they have a choice, and again, enhance their coping, which is huge. So that was my presentation. I hope that you all were able to gain something of use in all of that. Again, I was asked to go through those developmental stages, so hopefully, you know, if you have a child that's going through, or a patient that's going through and being with you for a while, you can see how at different developmental stages, hospitalization will have different challenges and stressors. Hopefully there were some tools in there that you found that will maybe be beneficial for you all to utilize, and then have a better understanding of what we as child life specialists do and try to advocate for, so we can best support your patients and children through, again, transplants, but through hospitalizations in general. So thank you all so much for your time. And I don't know if I'm seeing this correctly. I don't think there's any questions currently, but I might be incorrect. But if there are, please feel free to type some up. My information is here, so if anyone has a question that they maybe don't have at the moment, but think of something later or have any of your own concerns, please feel free to email me. This is a topic I'm very passionate about. I feel honored to work with our transplant patients here and with their families. It's so wonderful, and I'd be happy to talk with anyone. Thank you so much.
Thank you so much, Brittany. That was really, really informative. We really appreciate it. I have one question that we've heard from some of our parents around working with siblings. So I'm just going to mention it. So do child life specialists work with siblings, or perhaps coach parents with giving tips on how to talk to siblings who are concerned for their own health, perhaps that they would also experience the same disease or diagnosis that their sibling does? And do you have any suggestions around that situation?
Yes, absolutely. So we definitely work with that concern frequently with siblings, especially because, in all honesty, some of them have, it's a genetic thing that it could impact the sibling as well. So we really talk about with parents and siblings about what that's going to look like. So really discussing what they look like now, like how their health is now, and right now your body is really strong and it's healthy and you're doing okay. You know, if anything changes, you know, remember how we took your sibling to the doctor and we got things figured out, and look at how, you know, we're working as a team to make them feel better. So again, not necessarily saying, you know, yes, this is genetic and there's 90% chance you're going to get it, but reminding them of all the positive steps that have been taken to help the sibling. If perhaps the sibling has a negative outcome, focusing on the ways that the family and the team worked together and the positive things that occurred before the negative outcome. So really, again, focusing on the good things that occurred, focusing on the strength of that sibling at that time. But we do have a ton of handouts to provide, talking about just physical well-being, mental health well-being is an ongoing process. And so really we want to make sure that families feel well supported at each stage. So we always tell families, you know, how a sibling maybe is comprehending their sibling's diagnosis can change over years. You know, we think about a lot of our transplant kids that are listed for years and years, and their siblings are in that same waiting pattern, that same holding pattern with the sibling. And, you know, they're deeply impacted by the frequent hospitalizations or caregivers needing to be gone. So we really want families to understand that this conversation is ongoing and working with them at each stage about what that's going to look like.
Mm-hmm. That's great. That's really, really helpful. Thank you so much. Also do not see any other questions that have come in. So I'm just going to take a second to, if you have any questions, feel free to jot them down and submit them now before we conclude. But I just wanted to take a minute to thank you first, Brittany, for joining us and sharing your time and expertise with us today. That was really a great presentation. So we're really grateful to you. Thank you.
Thank you so much for having me. It was really wonderful.
Thank you. And I just wanted to remind everyone that during the week we are also doing another webinar, which is tomorrow, and it's going to be tomorrow at noon Eastern Time, and it's focusing on adherence and transition considerations. So we've shared the invitation on our social media and via email, and with the different organizations that have been participating and helping to invite their members. So anyone is welcome to join that. If you need help finding the where to register or have questions about it, you can email Melissa or myself, and our emails are right there as well. And also continue to check our social media and Melissa's website as well for Transplant Families, with some different additional awareness activities for National Transplant Week for pediatrics. I don't believe that we have any other questions, so we can go ahead and conclude today's presentation. Again, thank you all. Thanks, Brittany. Thank you all for joining us, and have a great afternoon. Take care, everybody. Bye-bye.